Good morning, everybody. My name is Gary Haugen. I am the National Sales Manager for Nascent Surgical. Our topic for today is surgical smoke generated by electrosurgical devices in the operating room. Before we get to that topic, that will be discussed at length by Dr. Leonard Schultz, just a bit about my background. I have been in the medical device business for 30 years. My career has expanded from quite a long stint with Medtronic to various other smaller distributor groups and selling various catheters and devices in the medical field.
My name is Leonard Schultz. I'm a general surgeon by training and have practiced for 25 to 30 years in the Twin Cities. My primary interest during that period of time was laser surgery and laparoscopy. And the topic today, current trends in surgical smoke evacuation, grew out of the interest in both of those topics. Laparoscopy resulted in a filter that many of you may be using for removal of smoke created during laparoscopy, but today we'll be focusing primarily on how to deal with smoke evacuation for open surgical procedures. I think that to begin this topic of surgical smoke evacuation, let's talk about the fact that surgical smoke has often been the elephant in the room. It's a problem that all of us recognize, but through the years we really haven't had a good way of getting rid of it, dealing with it, and so we just denied that it existed and went about our way. There are a number of hospitals that have said they are smoke-free. What they mean is that no one smokes cigarettes on or about their property. But are they really smoke-free? Not while they create smoke like this in the operating room, no matter what the heat transfer device may be. They may be using lasers, they may be using harmonic scalpels, or more commonly electrosurgical devices, but certainly that smoke goes somewheres. And you can see the problem of smoke because it rapidly rises, because it's hot, and it disperses because of Brownian motion. And the difficulty is, how do we capture that smoke when it travels through all portions of the operating room? As you know, there are probably about 500,000 workers in the operating room that are exposed to surgical smoke 5 days a week, or more, depending upon how much overtime you guys work. But it covers not only the surgeons and the perioperative nurses, but the anesthesia group, as well as the patients themselves, especially if they don't undergo general anesthesia with endotracheal intubation. Smoke has many components to it. The ones that we are very familiar with, of course, includes vapor, about 85% when electrosurgical devices are used, as much as 95% when lasers are used. They contain blood elements, viruses such as HPV, and today, of course, we always think about HPV and adenocarcinoma of the nasopharynx. No longer can that be hidden under a cloud of smoke, if you'll forgive the pun. And many chemicals, as many as 600 chemicals. A number of these have been considered mutagenic and carcinogenic by NIOSH, and they include chemicals such as hydrogen cyanide, benzene, carbon monoxide, methane, and formaldehyde. As a matter of fact, when you compare the smoke in an operating room with cigarette smoke, there really is no difference because they all represent the breakdown of an organic carbon-based compound, whether it's the human tissue, which is carbon-based, or whether it's vegetable, it's still the same. The only difference between the two really is the presence of nicotine in smoke. And there we're talking about a number of different things, because first we talk about the gas effect on our own system versus the effect of nicotine specifically on the vascular system. The hazards of surgical smoke are multiple. The simplest one, of course, is the odor, which can cause nausea and just a sense of discomfort from it. And the sizes of the particulate matters, as we now recognize that over 80% or approximately 80% of surgical smoke really represents nanoparticles. That is to say, anything less than 1/10 of a micron or 100 nanometers in size. This is a picture of a virus, and you can see the sizes. When we compare the sizes, the important thing to recognize is that the mask that you use does not protect you from inhaling any of these particular materials. Whether it's viruses that are very, very small, a couple of maybe 100 to 200 nanometers in size, less than 100 nanometers in size, versus mycobacteria, which is about 500 nanometers in size. Again, this slide is being shown to point out the components of surgical smoke and the importance of trying to avoid chemicals that are known to be carcinogenic and or mutagenic. The tissue particles themselves are either in the form of aerosols, such as bone dust that we see in orthopedic procedures, or other aerosol concentrations that grow by adding on. Also, the word that is used is accretion, where they get bigger and bigger in size. And then we have the concentration, which are the ones we're really concerned about, the ultrafine particles, which are another way of saying nanoparticles. In case you're concerned that you stand alone as far as requiring or requesting that smoke be removed from your operating room, and I'm speaking, of course, now to clinicians primarily, look at the list of all the organizations, both government and non-government, that support the idea of smoke evacuation. One of the governmental agencies that is primarily concerned with your health in the operating room, of course, is OSHA. We already spoke briefly about NIOSH, the research arm of OSHA, that has indicated that the gases released during surgical procedures include mutagenic and potentially carcinogenic gases. But the primary job of OSHA is to try to protect you through the general duty clause that says the employer is primarily responsible for your health during your period of employment, as well as the respiratory clause of the OSHA Act that talks about protecting you in terms of clothing to prevent blood splashback and so forth. This brings up the topic of the bloodborne pathogen rule. And back in the year 2000, a president of a medical device company asked the question of OSHA, does smoke evacuation, or actually the surgical plume, have the same ruling as protection afforded to the nursing group by the bloodborne pathogen rule that says you need protective gear, whether it's a face mask or protection of scalpels and so forth. The answer, unfortunately, that was given by OSHA at the time said, no, the bloodborne pathogen rule does not apply to elements within surgical smoke. The question is, does this make sense, and is this a proper ruling? Because a lot has been known over the last 12 years, 13 years since that ruling came down. And one of the things that we notice about the rule itself is that any potentially infected material is covered by the rule. And as you know, we've already spoken that blood elements are present in surgical smoke. The same body fluid that we are so careful to protect ourselves against because it's potentially contaminated is present in surgical smoke as vapor. So does it really make sense not to use the bloodborne pathogen rule to apply not only for protection against blood spatter, but also protection against inhalation of the same body fluid present not as a liquid, blood, but rather as a gas or vapor in surgical plume? And the answer to me is certainly no. The good thing is that each state has the potential to add their own amendments to these rules because each state has its own OSHA division. And I would certainly suggest to each of you that you look to your nursing group in your individual states to talk to the OSHA division of your state to try to amend the rule. The other regulatory agencies, government agencies involved in this include NIOSH, and we've spoken about that, talking about the fact that the gases released during smoke production include mutagenic and potentially carcinogenic gases, but they also advise that smoke, whether it's produced by lasers or electrosurgical devices, be evacuated. The American National Standards Institute, ANSI, they say the same exact thing. Smoke should be evacuated. ECRI, which is a nonprofit organization that tests various materials used in operating rooms, say the same thing. They recommend the evacuation of smoke, whether it's electrosurgical or laser smoke in origin. Finally, your own professional group, AORN, the Association of Perioperative Nurses, also recommend in their recommended standards that smoke be evacuated. The Joint Commission, who has more recently teamed up with AORN to try to get rid of smoke in the operating room, say the same thing, evacuate the smoke. International organizations, exactly the same. So as you can see, as we roll through all these various organizations, there's a commonality and an understanding that surgical smoke is something you shouldn't be breathing in on a consistent basis. So the question comes up as to if smoke is something that should be evacuated, but isn't more commonly than not, why do we bother? Why should we bother with removal of smoke? Well, there are a couple of reasons. The more obvious one is that it's been found that surgical nurses, perioperative nurses, have twice the incidence of respiratory illnesses than that present in the U.S. population. Another reason is that respiratory illnesses are the second leading cause of absenteeism in the OR. It might be interesting to realize that an article describing the cost of absenteeism from nurses in Canada exceeded $600 million, just to give you some idea of the extent of the problem. Furthermore, smoke has been implicated in respiratory cancers, and also there are future hospital liability risks, especially when the relationship between chronic inhalation of smoke components and the development of serious systemic illnesses becomes more widely known to the clinicians. And then comes the real argument that is starting to surface today, and that is the presence of nanoparticles in smoke and the fact that chronic inhalation of those nanoparticles, less than 100 nanometers, less than 1/10 of a micron in diameter, are the ones responsible by this process of translocation passing through the alveolar membrane, responsible for various systemic diseases. This is a slide that simply shows the data collected by Dr. Kay Ball, a former president of AORN, in a PhD dissertation in which she realized that through her studies that the OR personnel, the perioperative nurses, have twice the incidence of respiratory illnesses. I think administrators, hospital administrators, should also be aware that there have been litigation regarding the issue of proper environment, work environment for OR personnel and other hospital personnel. We already know the classic story of the plaintiff who worked for an airlines, who worked for an airlines and sued the airlines because of the contaminated air within the plane and won the case. In the case of another plaintiff, this one working for a hospital in Duluth, Minnesota, sued the hospital because of chemical odors present within a dialysis unit, and she also won her case. I think we may have spoken briefly about absenteeism, and that is the studies that have been done primarily in the educational industry, and the so-called sick building syndrome has pointed out that clean air reduces absenteeism significantly, and it was between 35% and 55%. And then administrators should ask themselves, what is the cost of that absenteeism in their operating rooms, especially if it is reflected by increased overtime costs and delays in the operative schedule themselves. Then there's another question that has been coming up primarily because of the importance of surgical. Of course, surgical wound infections are always important, but now they take center stage because the government has decided that they will not reimburse for surgical wound infections that are brought back into the hospital within 30 days of discharge. So the question is, could there be any ancillary benefits from smoke evacuation as regards wound infections? When we look at what we have done to date to try to prevent wound infections, it's really pretty impressive. I mean, we've looked at just about everything, from shaving, not shaving, different kinds of preps and so forth, to different kinds of antibiotic regimens, different kinds of wound closures. And yet, despite all of this, infection rates still persist. And on average, I would say that most hospitals report about a 3% overall infection rate, no matter what you do. So is it that we're missing something? We've tried various things. We've tried laminar flow rooms, we've tried space suits, but the studies seem to indicate that that really hasn't made a major difference in the effect on wound infections. So why do we consider the possibility that smoke may have something to do with wound infection? The reasons are as follows. We know that in laparoscopy, that when you insert a plastic tube, the trocar, between the smoke that leaves through the trocar and the body tissue itself, that wound infection rates decrease. We also know that if you put a plastic drape, such as the Alexis drape, over an open surgical wound between the smoke and the body tissue, infection rates go down. And then the last part of the puzzle may be that when you biopsy tissue, as they do for transplantation, to see if there's any growth, bacterial growth, there almost always is bacterial growth, which suggests that the patient themselves bring the bacteria into the operating room with them. Does that mean perhaps that when you use electrosurgery or laser that you are releasing those bacteria into the air to subsequently contaminate the wound? These are questions that I believe warrant further research. And so we try to do this by developing a sterile atmosphere, a glove box, in which we place contaminated meat contaminated with Serratia marcescens, and then exposed to laser, to electric cautery as coagulation only, and then as blended electrosurgical current, which is what we commonly use in the operating room, to see whether or not that bacteria injected into the meat would traverse the spaces within the sterile glove box environment. This is a picture of what it looked like with that pink meat in the center surrounded by 4 sterile petri dishes. And then distally off to the right, you can see a millipore sampling device, which also had a sterile petri dish filled with agar, to see whether or not any bacteria would grow at any of these 5 points following heat transfer to the contaminated meat. This is a very busy slide, but I think I can simplify it for you. In the second column to the left, you see the words CO2 laser, coagulation cautery, and cutting blend cautery. And then off to the right, you can see controls, which means that when smoke is present, no suction is on. In other words, there's no smoke evacuation. The colony counts were 0. Well, you would think that possibly there would be, except that it brings us back some 20 years of knowledge using the carbon dioxide laser when it was used actually to sterilize contaminated wounds when nothing else would clean them up. In other words, the heat transfer from the carbon dioxide laser was sufficient to kill the bacteria, so no aerosolization occurred. The same thing happened when coagulation cautery was used. Of course, we can't use coagulation cautery in an operation all the time because then we do nothing more than burn the tissue. But again, the heat source was sufficient so that when you look at the right-hand column, that there is no bacteria that grows out, no colony-forming units, CFUs. When the cutting blend was used, however, in the bottom part of this slide, you'll notice on the right-hand side under controls that in fact the colony counts, the colony-forming units were too numerous to count. What this means is that the cautery was able to release the bacteria from one site, the simulated wound, to a site 2 to 3 inches or 2 to 3 feet away where the micropore sampler was. So the bacteria were carried, live bacteria were carried by the smoke that was being produced. Now, if you look at the other columns, notably square and mini square repeated times 2, I want you to take a look. In this case now, suction was on, the mini square was working, it was connected to a standard smoke evacuator device, and we repeated the same sequence. And again, we have no colonies formed with CO2, no colonies formed with coagulation current, but there were no colonies present with the blended current. In other words, effective smoke evacuation in this particular experimental model resulted in no aerosolization of bacteria. Now, I want you to think clinically about an infected wound. You're cauterizing it, you're cleaning it up, you're debriding tissue, and the smoke is rising and you're not using smoke evacuation. Is it possible that the bacteria present in that infected wound are being carried throughout the operating room? This slide shows another aspect of what smoke evacuation, effective smoke evacuation, could do. In red are the colony counts present in the petri dishes immediately surrounding the simulated wound. In this case, what you notice is, in contrast to the control, that the two trays 3 and 4 have markedly reduced colony counts of contamination. We cannot account for tray 4, which has 54 colony counts greater than the control, and I have no explanation for it. But at least 5 of the 6 samples did show reduction in colony counts, significant reduction in colony counts. So then what is the possible advantages of superior smoke capture? Effective smoke capture obviously can prevent aerosolization of bacteria. As you know, we currently try very hard to prevent the bacteria from remaining in the operating room by chemical means, and now more commonly by ultraviolet light exposure. This would be a preventative measure rather than a curative measure. And it also has the potential to reduce simulated wound contamination. There have been no studies that I know of using smoke evacuation to date to see what effect it would have on reducing surgical site infection rates. So, kind of in summary, why do we need to solve the problem of surgical plume? The obvious one is what we know already, that surgical plume contains chemicals that are both mutagenic and carcinogenic. We also know that they contain live viruses and bacteria, and that live viruses, especially HPV, have been known now to be associated with adenocarcinoma of the nasopharynx, and in increasing amounts, so that this is not an anecdotal problem. This is a commonly associated problem when there is exposure by the surgeons, especially to HPV through venereal wart fulguration. As well as the next topic that we want to talk about, and that is diseases caused by nanoparticles and the fact that your surgical masks do not offer protection against inhalation of those nanoparticles. We've already mentioned that 80% of surgical plume is, or rather are, nanoparticles. We mentioned that they undergo macrophage phagocytosis when they enter into the alveoli and become part of the phlegm that is removed by a process known as mucociliary elevator that carries it up and out of your respiratory tree into your GI tract, where all these materials are eliminated. The problem is that the smallest of these nanoparticles, especially the 20 to 80 nanometer sizes, can cross the alveoli when they're present in high enough concentrations. The process is called translocation, and then enter into the circulatory system and the lymphatic system, and then they go throughout the body. What diseases do they cause? Well, this is a list of not everyone, but these are the majority of the diseases that chronic inhalation of nanoparticles are associated with. They include neurodegenerative diseases such as Alzheimer's disease and Parkinsonism, various autoimmune diseases such as collagen disease, lupus erythematosus, and rheumatoid arthritis, various respiratory and distant cancers, especially breast, pancreatic, and prostate cancer, arteriosclerosis, cardiac arrhythmias. Perhaps some of you know of other employees, colleagues in the operating room who have undergone endocardial ablation because of cardiac arrhythmias. This is one of the things which chronic inhalation of nanoparticles is associated with, as well as coronary artery disease. All right, so we've talked about current technology, the underlying reasons for smoke evacuation. Let's look at current technology and how to use it. Briefly, surgical mask will protect against 5-micron particulates in the smoke, but not that down to the micron level or submicron level, i.e. the nanoparticle level. You folks have probably used Yankauer suctions to try to remove the smoke. You know that doesn't work very well. Probably the first device used was the suction wand, which was originally 6 inches of hard plastic attached to a 7/8 inch ID smoothbore tubing, also called respiratory tubing because the anesthesiology people use it. And it was connected, the Yankauer suction is connected to the wall suction, whereas the wand with respiratory tubing was connected to the smoke evacuator. This is what a current wand looks like. It's a cuff tube of just corrugated tubing or smoothbore tubing, and you just follow the smoke. So somebody has to follow the smoke plume to collect it, because the opening is only 7/8 inch wide, and the electrosurgical unit pencil, which is currently used, is a monopolar electrode, which means it can only be used for monopolar cautery, with an embedded 3/8 inch tube, flexible tubing, usually connected to an inline filter and then to the wall suction, although more commonly today they're adapting it to a direct connection to the smoke evacuator, standard smoke evacuator. This is a problem with the ESU pencil. You can see the tip of the tubing has to come fairly close to the tip of the electrode in order to capture smoke. But the problem is that if you do that, then the surgeon can't see the tip of the electrode and it's hard to operate. So they pull it back, When you pull it back, because the closeness of the orifice to the source of smoke is so critical to smoke capture efficiency, that the efficiency drops off significantly as the ESU tubing is pulled away from the tip of the electrode. The other issue that is the physical principle, and that is how much airflow can you get through a certain size tubing. So this table shows the 3/8 inch tubing, which is about 6 millimeters in internal diameter. This is what's attached to the ESU pencil. It shows the 22 millimeter diameter tubing, which is what we commonly call the wand, and you can certainly follow the plume of smoke as it's being produced, but it takes somebody to do that. Or the 25 millimeter tubing, which is 1¼ inch tubing. And you can see as you follow along that the tubing area rapidly increases with size. That's obvious. But the important thing is the cubic feet per minute of airflow that you can get through these tubes, given wall suction, which is about 5 cubic feet per minute. If you attach it to a smoke evacuator, you can probably get up to about 11, maybe 15 cubic feet per minute. Whereas the other larger tubes, 22 and 25 millimeters, have pretty high airflow rates of up to 30 or even 50 cubic feet per minute. It should be pointed out, for effective smoke evacuation, at least 22 cubic feet per minute is needed, preferably 25 to 35 cubic feet per minute. Does a great job of capturing not only the smoke, but the ambient air above the smoke, which really serves to push the smoke toward the collection site. Now, the ideal product for smoke evacuation, of course, would be one that collects 95 to 100%, or at least 90% of smoke. It should have minimal setup time, should be easy to apply, designed for open surgical procedures, doesn't interfere with surgical vision, which to surgeons is a real issue, of course. And it's compatible with most of the OPA filters that we use to collect and filter, not collect, but filter the smoke, and then and something that will allow at least 25 to 35 cubic feet per minute of airflow. This is an early version of a product that did it's a cell phone product that was called the Square, but you can see from the appearance of it, too complicated, too much connecting. So nurses looked at it and said, well, we don't care if functionally it collects 110%, we don't want to bother with it. But its placement was simple enough. You applied the antimicrobial to the skin, you let it dry, and then you would simply apply it and it would circle the wound. And then this would be the tubing would then be handed off and hooked up to the smoke evacuator. Well, after about 1.5 years of clinical trials, it soon became apparent that nurses wanted something that was easier to apply and very quick to apply, and that was the current product that you're looking at now, the Mini Square. It is applied close to the line of the incision. And preferably, we would prefer that it be connected to a central vacuum system, which you can see being done on the right-hand side. But most smoke evacuators today do not have central vacuum systems. They have desktop units. Those are the ones that you'll be using, or a product like the Stryker Neptune unit, or Dornock, I think, also has one of those. This is a result of a study done at the University of Minnesota Particle Tech Lab, the Department of Mechanical Engineering, simply indicating the effectiveness of the Mini Square and the Square product, an earlier iteration, versus the ESU pencil under the same circumstances. So we have various kinds of smoke capture devices. We have a wand, we have the electrosurgical unit pencil, and the cell phone technology called the Mini Square. You can see the average smoke capture efficiency. The important thing to remember about the wand is it has a very high smoke capture efficiency, but only if kept within 1 to 2 inches from the source of smoke. If it moves up to 3 inches from the source of smoke, the efficiency drops down into the 50% level. The evacuation systems have multiple components to them. They have a smoke capture device, we've just talked about those, with tubing of various sizes, the smoke evacuator, which can be desktop, or it can be a central vacuum system, a filtration system, which almost always is an ULPA filter, an ultra low porosity or penetration air filter, which is used to filter the smoke that's collected, and then it returns the effluent back into the operating room, and various kinds of suction devices. Now, when you consider the smoke evacuation system that you want, you should be considering ease and portability, the noise level. Most of these operate at 55 decibels or lower, which means that they won't hurt your hearing. When they get up to 60 decibels with an hour or more of continuous use, you can start having difficulties with your hearings over years. It doesn't happen overnight. The only time it happens overnight is if you're at 90 decibels or louder, which is a jet plane, then you're exposed to it for about a half hour to an hour. You can actually have diminished hearing. It's got to be easy to activate and deactivate. We recommend that smoke evacuators should be put on before any smoke is produced, because once it goes up your nose, it's a failure. You don't get rid of it, and nothing will satisfy you. The filter change criteria, these filters, would you go back one, please? The filter changes usually now are mechanized with a, I forget what they call them, they're chips. These chips that say after a certain amount of time, get rid of it and change the ULPA filter. But the best way to really know is put your nose right on the effluent side of the filter, and if you smell smoke coming out of there, it's time to change. The maintenance for most of these are pretty minimal. There aren't many things that go wrong with them. And then, of course, the system has to be equated in terms of cost efficiency. This is probably the first smoke evacuator on the market. It was created by Emil Stackhouse back in the mid-1980s. The noise level is beyond my wishing to tell you, but it was certainly more than 55 decibels. And you can see the tubing connected to the ULPA filter, which hung off the side of the machine. Today, these filters are all incorporated into the box itself to make it look a little sharper. They were very loud, but they worked. They worked if you were able to follow the smoke. Today, these are the common smoke evacuators that you see. They're stand-up. They either sit on the desktop, or they are on canisters, and you can wheel them around. But they all do about the same. They all do about 25 to 35, up to 45 cubic feet per minute of airflow. And they operate at the same decibel level for the most part, and they're fairly effective. Wall suction is not effective. I want to say that again. Wall suction is not effective. It was meant to remove fluid. It was not meant to remove smoke, which requires much more air volume than fluid does. So we don't recommend them, but you can see an example of an inline filter that consists of ULPA filtration and activated charcoal, as do all of these ULPA filters that are commonly used in the operating room. We've already spoken about these. These ULPA filters, next slide please. These ULPA filters sort of look like this. They have a pre-filter material. They have the actual ULPA filter, which is usually a microfiber glass material, although I think one company has its own proprietary filter material. The activated charcoal is to absorb the chemical odors and the chemicals themselves, and then a small post filter before the filtered smoke leaves the filter back into the operating room. There are barriers to adoption. Probably the biggest one is surgeons' resistance. Remember, these guys want, and myself included, would want data-based evidence. We don't want marketing hype. We want data-based evidence. And we want to know that we're doing it for the right reasons. We don't like the machine. It oftentimes distracts us from the operation itself. But frankly, over time, the noise becomes secondary. It's white noise as the surgeons go back to focusing on their patients. Therefore, we recommend you start at a slightly lower strength. And once they get into it, the first minute or so, you're back up to 100%, but don't let that interfere with collecting the smoke. If your surgeon starts right away and you need 100% power, then it's 100% power and they'll deal with the noise because they all acclimate to it when they see the effectiveness of getting rid of the smoke. The facility considerations, there's no substitute for a policy, a smoke evacuation policy, published by the hospital. Everything else is catch as catch can. The nurses are usually in favor of it because that's their work environment. Nobody smokes in their house. Visitors can't smoke in your house. They go out in here in Minnesota, they'll go outside in the frigid weather to smoke, but not in your house. But they live with smoke all day long in the operating room for 20 and 30 years of their career. It's nuts. But then again, if the surgeon says, I don't want it, I don't want to use it, they usually defer. To help them, the nurses have to go to the administrators who will respond to the clinical requirement, and the smoke evacuation policies will eventually be promulgated and then accepted by the surgeons. Otherwise, it's an individual case-by-case basis. Usually the older guys, they don't want it. The younger guys, they don't want to live with it, so they'll be helpful and they'll be advocates for you. As far as the staff considerations are concerned, those policies, of course, require that you have expertise and knowledge in these matters. This is one of the reasons why we created this video. I hope it will be helpful to you. And then to review this annually. Are we maintaining the information? Are we adding to it? Remember that compliance is not universal. OSHA and the Joint Commission have guidelines. They don't have mandates, and we shouldn't be looking to the federal people for help in this regard. It's not going to be there. Education is the key. Education leads to an interest, a genuine interest in smoke evacuation, which will then carry to eventually smoke policies in the hospital. Because right now, to give you an idea, when Gary and I went to Canadian hospitals to demonstrate this product, you walk into those hospitals where smoke evacuation is almost universal. You do not smell smoke. You do not smell burnt bone. You smell clean air and breathe in, not smell, but you breathe in clean air. There's no reason why the United States hospitals can't be as good as the Canadian hospitals at providing a safe respiratory environment for the perioperative staff. That's it. If you have any questions, please get in touch with us. Otherwise, have a great day, and I hope you've learned something from this talk.
Just one further note, I want to thank Dr. Schultz for spending some time giving you some detailed information on smoke. Please note, as you review this topic and presentation by Dr. Schultz, that there is documentation. Everything we have told you and he's addressed today is documented with factual information. And lastly, please consider the fact that when you approach work, your hospital place of work, you can't smoke a cigarette even on the premises, much less in the premises. However, smoke is allowed in the operating room, and as Dr. Schultz has just pointed out, the only difference between that smoke and cigarette smoke is nicotine. Thank you for your attention, and if you have any questions, please contact us. Our web information is nascentsurgical.com, and we will respond to your questions with a telephone call or a written email. Thank you again for your time.
Thank you.